Welcome back on the AM show. As announced, we're going to focus on malaria, how far we've come, what gains, what strides we've made, and what the way forward is. Joining us for a conversation, we have the focal person, malaria case management at the Ghana Health Service, Dr. Paul Boateng. He joins the conversation. Doc, Fabume, good morning.
Good morning.
Thanks for coming.
Happy to be here.
Great. Yeah. Malaria, so let me just make this known.
Okay.
I love animals, all animals and everything. And if they are not a pest for me, I let them be, even spider ants and all of that. But when it comes to mosquitoes, Charlie, me and them, we know they find crap because they can. I was just sharing with you that I've not been so well.
Yes.
Especially yesterday. I'm much better today. I think there may be some things in there I have to get checked.
Okay.
But malaria, I don't think is anybody's friend, right?
Yes.
What would you say is our status now when it comes to malaria? I just want us to start from the here and now. Okay. How far we've come, and then we can backtrack and take it from there. What's Ghana's status when it comes to malaria?
Okay, so currently we'll say that malaria is endemic.
Endemic?
Endemic in
still.
Ghana. Yes, still endemic. But what it means is that we have made a lot of progress over the years. So the burden of malaria has reduced drastically over the years. And as you mentioned before this, at the start of this interview, we're recording so many cases some few years back. But that's the prevalence of malaria was very high some years back. In fact, in the early 2000s, the prevalence was around 50 to 70%. What it meant was that if you randomly sampled 100 people on the streets and tested them for malaria, about 50 to 70 of them will have malaria parasites in their blood. That was how bad it was. And this has reduced consistently over the years, based on several interventions that have been implemented. And as of last year, our prevalence rate as a country was around 8.6%. What that means is that if you randomly sample, again, 100 people randomly across the country, just 9 of them will have parasites in their blood. So that's great, tremendous progress. When you look at deaths due to malaria as well, so we're recording deaths in the thousands some few years back. But as of 2022, our deaths were around 151 deaths, and that's a very significant improvement. And so, yes, malaria is still endemic, but we've made significant progress over the years as a country.
I see.
Yeah.
And now talking of all of this, what have we had to do over the years, from the early 2000s to the 2012s, 2013s, to get to where we are currently? And let me just let you know, those of you watching us, that at some point we'll activate the phone lines so we can have conversations on these matters. I know that in different parts of the country, the endemic position is more or less. Yes. So you can also call through and share your thoughts with us as we have this conversation.
So just before I come to that, as you mentioned, the prevalence is high in some parts of the country and lower in some other parts. So for instance, as of 2022, from the Ghana Demographic and Health Survey, the highest prevalence was in the OT region, which is 15%.
OT?
Yes.
15.
And the Greater
That's
Accra
my region.
Oh, that's your region.
It
okay,
is.
That's great. And the Greater Accra region had the lowest prevalence of 2%. And so, of course, the prevalence is not even across the country. But you asked about what we have done to be able to bring down the burden of malaria over the years. And I think that one has to do with use of preventive interventions, deployment, and making sure that preventive interventions are used. And one key one is the use of insecticide-treated nets. And I know we've gone through a lot of stages where it was just the nets, then we impregnated them with the insecticides, and now we have the insecticides impregnated on the nets itself. So you don't have to now put it in a chemical and now hang them up. And so we've been able to do this net distribution over the years, and we've made sure that a lot of households have nets. We're ensuring that people use these nets as well. The other interventions we've rolled out is what we call indoor residual spraying. Indoor residual spraying is that you spray the inner walls of various houses, with insecticides. And what happens is that because the mosquito that transmits malaria will usually bite indoors and rest on the walls. When they rest on the walls, these insecticides will kill them, and then will reduce the transmission of malaria. We've also had other interventions such as what we call larval source management, We know that mosquitoes that transmit malaria breed in collections of water. And so what this intervention does is that they identify collections of water where the baby mosquitoes are what we call the larvae or the pupa. And then once they identify them, they spray them with environmentally friendly chemicals that are able to kill these larvae and pupa, prevent them from growing into adult mosquitoes and transmitting malaria. We've also been able to improve on access to healthcare, particularly malaria diagnosis, that's testing and treatment. You realize that we've had several interventions where we've made sure that now we have rapid diagnostic tests virtually everywhere across the country. Some years back, it wasn't so. So you can even test in over-the-counter medicine shops and pharmacies, make sure that you are tested before you are treated. And also make sure that ACTs are readily available across several parts of the country. These are just a few. There are many more I could talk about. But just
I know of some paint for buildings that have components that can, I think, prevent all of this. Is that something else you've also looked at?
Yes, I mean, it just works just like the indoor residual spraying, basically the same kind of insecticides that are used. Of course, there are different insecticides, but we have to look at what the paint that are being used. But they're also effective in terms of killing the mosquitoes and preventing malaria transmission as well.
Is it the consistency that has brought us this far? Of course, I'm looking at the figures, and maybe I'll come to you for some part of the regional distribution, because OT region 15% is pretty high compared to the average of 8%. That's almost twice the national average. And then you have a very low rate in the Greater Accra region. I'm wondering in there, is it more education? Is it that the population in the Greater Accra region is more of something compared to other? I mean, what are the dynamics in there?
Yes, so I think you mentioned it. One has to do with education and also what we'll call wealth levels of the people. And once they are wealthy, they'll have...
So the capacity to buy.
Yes. So one has to do with education. So once they are aware of how malaria is transmitted, they don't have very negative perceptions of how malaria is transmitted, and they are implementing those preventive interventions, then they are more likely to get malaria. Also has to do with most of the time those in the urban areas have improved housing, and so they have less bites or less mosquitoes within their rooms and less bites as well. And also access to healthcare. Okay, so those in the urban areas like the Greater Accra region have greater access to healthcare compared to those in the rural areas. So these are some of the few things we could say. We also implemented a number of interventions within the Greater Accra region, like larval source management, which we believe has also helped contributed to the reduction in the burden of malaria in these areas as well.
Now, even with the 2% in the Greater Accra region, I believe there are more. You say you are talking about larval source management, among others.
Yes.
There are some places you go by and you see, I wouldn't call them swamps, but collections of water, and you can see these mosquitoes there.
Yeah.
There are these types even that they skid on water. I don't know whether they are much bigger. I don't know whether they are a form of mosquito as well. But sometimes you pass by some of these areas and you see them and you know that, no, something is definitely wrong. It's breeding mosquitoes, and these mosquitoes will end up, biting people, and we have some susceptibilities in there. But is there a drive, basically, to completely eradicate this? There's a reason I'm asking you that question.
So we recently launched our National Malaria Elimination Strategic Plan. And that plan details how we intend to eliminate malaria from Ghana. And as you mentioned earlier, the regional distribution or the burden of malaria is different in different parts of the country. So the approach we want to use is to make sure that we start in areas where the burden is very low, try and eliminate malaria in those areas first. In areas where the burden is very high, we work at reducing the burden further and to be able to eliminate malaria across the country. So in this strategic plan, elimination strategic plan, that spans from 2024 to 2028, there are three broad goals we want to achieve. One is to make sure that we reduce the mortality, deaths due to malaria by 90% by 2028. The second goal is to make sure that we reduce the incidence of malaria by 50% by 2020, using 2022 as baseline. And then there are 21 districts, coming directly to your question, 21 districts in the Greater Accra region, where we've already observed that the burden of malaria is very low, less than 1%, where we want to deploy interventions that would help us be able to eliminate malaria in those districts by 2028. And some of those interventions we want to deploy, yes, the larval source management is one of them, and it's very key because it will help us to also be able to reduce the numbers, okay, of the new mosquito species called Anopheles stephensi, which we detected in some parts of the Greater Accra region, which we are taking efforts to make sure that we curtail the negative impact of some of these.
And those are much more tricky to
Yeah, they are much more tricky.
Anopheles stephensi. I think some months back, last year or so, we're talking about them. And it's just become, because now, even if you look at the cocktail of drugs we have to take, gone are the days when you would take chloroquine and you were good. You would feel the itching, take some Piriton, and you were fine. Now we have artesunate, is it amodiaquine, and then the lumethrafrins and all of those.
Lumefantrine. Yes.
So it's becoming complicated dealing with them.
That's the mosquito. I think that so far we are containing the situation. They have a risk of increasing the burden of malaria in urban areas particularly, but I think so far the situation is under control. And so some of the interventions we hope to implement in these 21 districts will help us push or accelerate progress towards elimination in these 21 districts. And some of them will include, so in the Greater Accra region, for instance, you won't just be treated with ACTs if you come down with malaria. We'll add one more medicine to it that will be able to clear all stages of the parasite and therefore block transmission, prevent the mosquitoes. Even if they bite you, there won't be any form of the parasite within you for them to transmit to another person, for that person to.
Oh, I see what.
And there are, as I indicated, also there are environmental interventions like the larval source management that will be implemented to make sure that breeding sites for mosquitoes are also well controlled, together with a lot more other interventions that we hope to. There's also what we call the mass drug administration. We also piloted earlier this year and then also scale up based on the lessons we learned. But what that involves is that almost everyone within a particular geographic area will be dosed with an anti-malarial, clear any parasites within the person, and therefore once there are no parasites, if you're even bitten by a mosquito, there won't be any parasites to be transmitted. Right. So those things will help us be able to achieve this elimination agenda in these 21 districts as quickly as possible.
Okay, so now let's look at the rate, the prevalence rate in the different regions.
Yeah.
You mentioned 15% in OT,
yes,
which is a worry for me because I come from that part of the country. 2% in the Greater Accra region, that is okay for me because I'm in this region. But let's look at the dynamics across the board. Okay. What's it like in the Ashanti region? What's it like in other regions that are topical?
Okay, so as indicated, the Ashanti region I'd have to check the figures.
Okay.
But
you can go ahead and check.
Okay, let me just quickly.
We'll just quickly get there so that we can know what the figures are for each of those regions. Of course, we'd like to see what the breakdown is. And that's why we're also inviting you to call and share your thoughts, because malaria is everyone's problem in Ghana. I mean, most people, if they are ill, it probably is malaria. I'm not saying it always is, but it probably is. It's a very endemic situation here. So that's why we're having this conversation this morning with the focal person, malaria case management at the Ghana Health Service. He's in the person of Dr. Paul Boateng. He has the figures now ready for us, and we'll be activating the phone lines in a bit to get your thoughts. But back to you, Dr. Boateng. So
yes.
What is the tale there?
So in the Ashanti region, we have a prevalence of 7.5%.
7.5 in the Ashanti region.
Yes.
That's very close to the national average.
Yes, that's a bit close to the national average.
Okay.
Yes.
Then from there? So I'd like a breakdown of
each of the regions,
yes,
the prevalence.
If you have.
Oh yes, I can give that to you. So the central region has 9.6%.
Central 9.6.
Yes. Okay. Western region 9.7.
Okay.
Western North 4.4.
Okay.
And Volta region 6.4%. OT region we said 15% already. Eastern region 6.7. Bono we are having 12.1. Sorry, Bono 9.9. Bono East 12.1. Ahafo 11.8. Northern region we are having 10.6.
Okay.
Northeast 10.3. Savannah 12.1.
Okay.
Upper West 13.4 and then Upper East 12.2.
Okay, yeah. So Upper East 13 point. Did you say 12.2?
Upper East 12.2, yes.
12.2.
Yes.
So if you look at it, then it means with the Ashanti being at 7.5, let me just take a look at this. Central with 9.6, Western with 9.7. Those are pretty high. Bono with 9.9 is also high. But Bono East, our very own Director of Health Services there, he's a colleague, 12.1%. I know, and I'm only mentioning this because I know he's not going to be happy about that rate. He would want it to fall a bit more. He's a very passionate man when it comes to health, and I know that he would be worried about that situation. We wish you the best on that. Then there's Ahafo with 11.8, and then Savannah with 12.1, Upper East with 12.2. So if you look at it, those with pretty high, let me see, 1, 2, Upper West with 13.4.
Yes,
3.
Upper West 13.4, yes.
Then you have Oti with 15.
So generally you realize that...
Bono East with 12.1. These are, you have about 4 or 5 regions with very high numbers.
Yes, but you have to look at it against the previous...
Against what it used to be.
Yes.
So the 50 to 75% prevalence.
Yes, we've come down drastically over the years. When you look at 4 years before that, the rates were much higher. Yes, the rates were much higher. So there's a much improvement over...
I get the point you're making, but I'm saying that comparatively. Look, if you can have a region with about 2%, which is the Greater Accra region. I believe that's the lowest, right?
That's the lowest, yes.
Okay, so Greater Accra with 2%.
Yeah.
And then you have another orbiting around 13%. I know the dynamics, even the living areas and conditions.
Yes.
So more places with plants, mosquitoes will tend to. Greenery and all of that versus the concrete jungle of Accra. But I'm just saying that we have to find a way of getting them at par at some point. And that's why I asked you about the plan moving forward. And you shared that national plan.
Yes.
So looking at these figures, what then is the strategy to bring all of them into alignment?
Okay, so the strategies span across different areas. And as you indicated, each area has its own unique peculiarity, and the burden is different. And so we try to use data to deploy interventions that are effective, okay, and that are context appropriate, okay. And so, for instance, in areas where the burden is very high, there are key interventions that we hope to deploy in those areas. So areas with moderate to very high transmission, we are looking at interventions such as larval source management. Interventions such as indoor residual spraying. I mentioned they have to spray the inner walls of those houses to make sure that they kill the mosquitoes when they land on the wall. So that's one of the interventions we hope to deploy in those areas. We also hope to deploy intermittent preventive treatment of malaria in school children. Okay, so we realize that we have a number of interventions for children under 5, but relatively the burden has reduced in those age groups and now relatively shifting to those just about 5 years. And so in that particular age group, we hope to give them medicines regularly to make sure that we clear any parasites within their system and to reduce the burden in those age groups as well. Also, we hope to deploy what we call, sorry, let me just quickly check that.
That's fine.
Yeah.
That's fine.
So that's for the moderate to high burden area. So we have what we call seasonal malaria chemo prevention.
Seasonal malaria
chemo prevention.
Chemo prevention.
Chemo prevention, yes. So that is
Once I heard chemo, I got a bit... what does that mean?
So that is for children, children less than 5 years. So you realize that most of the areas with high burden of malaria are usually towards from the middle to the upper, to the northern regions. And in those areas, you realize that malaria transmission is very seasonal. So a lot of the malaria cases occur within the rainy season. And so what we do is that for children who are less than 5 years, who are at high risks of severe malaria and dying from it, just at the start of the rainy season, we give them an anti-malarial and give them every month towards the end of the rainy season. That has been found to be very effective in reducing the burden of malaria and reducing deaths and severe disease in those age categories.
And of course, we know that children are especially vulnerable when it comes to this.
Under 5.
Those of us who have been bitten so many times, we develop some sort of immunity.
Yes.
You can still, fall. And I hear there are some blood groups that deal better with the parasite versus other blood groups. So, but you don't want the viral or the burden to be too high, because then it could even take your life. But focusing on the children, what's the rate of prevalence? Does this reflect on the children as well in all these areas?
Yes, it reflects on the children, yes. Usually, even in this study, we use children to give us these national statistics.
Okay, so that you focus more on children?
Yes.
The prevalence among children.
Yes.
I have a message coming through. It says, the government has not prioritized the building of hospitals and health issues in general so that fighting of malaria will be achieved. They are only interested in, in how to make money for themselves and their families at the expense of the taxpayer. Which brings me to another question.
Okay.
When it comes to, of course, yes, some things have been done in tackling malaria. Government will tell you about Agenda 111, which some people will tell you will not materialize before this term is over. But what would you say the fight of malaria has been like, the push financially, logistically? How much do you have available to you? How much more do you need to be able to reach out further and ensure that what you want to do can be achieved? I always go back to this point. I've lived in Cuba before. Cuba found a way. Yes, they may have in that part of getting into South America, Zika, there's this other one that doesn't come to mind. But they may have those, but they don't have malaria. They've eradicated it. What's your reaction to that? I don't know why we're still here and can't do something about it. Is it because of where we are?
Well, our climate also contributes to...
Yeah, that's why I'm asking. Is it because of where we are?
Yes, our climate contributes to that. But what I will say is that there are other African countries that have been able to eliminate malaria. And most recently, just about a week or two to our game against Cape Verde. Cape Verde was declared malaria-free.
Yeah, so they've beaten us in terms of
not just
being
football,
malaria-free, and they beat us in football too. They are beating us everywhere.
Yes. But you asked me about how much you would need for us to be able to implement this strategy.
How much are you getting, first of all? How much more do you need logistically?
Well, we hope, and it's just hope, that we could get maybe close to about $1 billion.
$1 billion
Yes. But
just to clarify, you mean 1 million or 1 billion?
1 billion. But you see, the strategic plan is estimated to cost about $3 billion.
Okay.
But of course, we are looking at it not just about health sector activities, but all sectors implementing activities or interventions to make sure that malaria is brought down. Okay. But we are hoping to get maybe 1 billion, but we have a deficit of about $2 billion. And I would call on the private sector, on other non-governmental agencies to come in to support the fight against malaria. Because when you invest in malaria, the returns on investments are very high, about 1:22. And so we would call upon the private sector to help us be able to bridge this funding gap for us to be able to bring the burden of malaria down. Sometimes people may think or see malaria not to be so serious. And it's one of the challenges that we face. And we try to make sure we educate people to realize that malaria is a very serious illness. It affects virtually almost every vital organ in your body. And just recently, I encountered a patient's parent at the Kolibu Teaching Hospital whose child had developed stroke because of malaria. And most
a stroke?
Yes.
On the back of malaria?
Yes. And so malaria can affect basically all vital organs in your body. So from your brain, to your lungs, to your liver, to your kidney.
I was just about to mention the liver.
Because kidney failure. So all the key organs in the body, malaria can affect.
How about your brain? I've heard things in the past.
Affect your brain. So we realize that children will come up with what we call cerebral malaria. It affects your brain. You are confused, you are unconscious, you are in coma, okay? Sometimes if they're able to even recover, they may come down with some cognitive deficits, okay? So they are not able to do well in school. They may have neurodevelopmental, motor defects and all of that. So malaria is a very serious illness. So it's important that we give it the necessary attention. I'm not think that, we just go and buy some ACT and we should be fine. No. Malaria can easily kill. And those countries who realize that malaria is a serious illness are taking steps to make sure that they eliminate malaria. Even China also just recently eliminated malaria. Look at the size of China, the population of China, but they deliberately took steps. Okay, they have a very high number of cases, over 30 million cases. But over the years, they took deliberate steps and they were able to eliminate malaria from this. So what it means is that Once you have the vision, you are committed to it, and you put in the various interventions in the right way, you should be able to eliminate malaria, just like other countries have been able to do that. You realize that, for instance, if you are recording about, let's say, a little over 5 million cases, which is even an underestimate, okay, let's assume that an ACT will cost even 10 cedis. 10 cedis times 5 million will be what,
50 million.
Okay. Now, assuming that, okay, you were given ACT, they added paracetamol to it, and sometimes you may add other medications to it. Now, assuming that, okay, the transport that you took to the hospital is not added. When you went there, probably you are admitted, okay, the costs of hotel or whatever, hostel or whatever, and all those things, it makes the cost of malaria very, very high. Not adding the cost of these other interventions that we are doing is very, very high. But of course, if you're able to invest in malaria and able to eliminate malaria, we will significantly bring down this cost. It costs us about 6% of our GDP virtually every year.
Right.
It's something that we need to be serious about.
Malaria costs about 6% of our GDP every year.
Yeah.
In other words, in malaria, it is maybe truer than in other cases. Prevention is better than cure.
Yes.
Prevention is the best option. And you look at its impact on productivity. But just to confirm, so you said that you would need about $1 billion. Is it to eradicate malaria or just for, within which period? Is it to eradicate malaria or within a specific period to aid the fight against malaria?
So to aid the fight against malaria. Remember, I'm saying that all these things it's composites. Not just the health sector, but all other sectors. Because if you want to eliminate malaria, it is not just the health sector job. All sectors are important. All sectors are supposed to come on board, from education to environment, sanitation, all agri, and all of them are supposed to come on board. And so this is for the period of 2024 to 2028, putting all these sector activities together and make costs about that much.
I see. What are your thoughts? You can reach out to us 0302-211-691 extension 2, 0302-211-691 extension 2. How do you think we're faring when it comes to the fight against malaria? What is the case in your specific community, and what more do you think we should be doing? What are your expectations? You can call those numbers with your questions. Kwabena J says, Ben, I think this malaria eradication must be supported by all. We with O blood groups are said to attract more mosquitoes. Is that true? He's asking. I am in the O bracket. And I know a lot of people. I think O has quite a number of people in there in terms of the blood group.
Yes.
Is that correct?
Yes.
Compared to the ABs and the
I'll have to cross-check that. But I think
others.
I'll have to cross-check that. Yes. So yes, the O's, I think that in terms of protection against...
I think he's suggesting that O's are more susceptible, not that they are more... But I was talking of the blood type O, whether O positive or negative, being there are many more people, human beings, who are of that blood.
I have to cross-check.
from what I have seen in the past. But anyway, back to you.
Yeah.
Okay, so we have a first caller, Patricia from Tamale. It gets pretty humid there. Patricia, good morning.
Good morning, sir.
I would appreciate it, Pat, if you could just raise your voice a little bit. What do you have for us this morning?
This morning, I'm grateful to speak to you, especially in the National Focal Subject. I want to thank you very much for the efforts we are putting up in order to eradicate malaria in the country. But my aspect is concerning the Greater Accra prevalence rate being so low. I would like to find out if the pharmaceutical, the pharmacies, the chemical shops that are also testing and treating, some not testing and treating, are they able to capture those data in order to act? But when you look at the northern zone, they probably the waiting zones, health centers are so close to the people, they are able to attend the facilities, and then let me say the testing and then the treatment probably may help with the prevalence being so high, even though it's coming down across the years. But when we compare the northern with the southern, education and other things, the literacy rate is higher in southern sector. And therefore, I think probably some of the measures they are able to control than the northern zone. But then, are they also taking data from the pharmacy shops, the chemical shops, in order to add and compare?
Pat, so basically what you're saying is that in the southern zone, there's more density when it comes to hospital facilities or clinics, so people could go there. But when it comes to the northern zone, you may not find too much of that, but you may find a lot of people going to pharmacies and getting treatment from there. That's what you're saying.
I'm saying in the northern zone, because of the CHIPS compound,
Okay.
very close to the people, you see that they prefer to attend the health facilities, and so capturing of the data is easier. But I'm trying to find out from the southern zone, education is also a bit higher there.
Right.
So probably someone may think going to the hospital is stressful. Let me just get to the pharmacy shop where they can test and treat. So I want to know whether they're able to capture data from them to add to the health facilities in order to compare.
Right. I now get your point. Thank you very much, Pat.
Thank you, sir.
Thank you. Any quick response to that?
So currently, our national data does not include that from the pharmacies and community pharmacies and over-the-counter medicine shops. But what we do is that we try to estimate, based on the deficits in the data that we have, knowing that we don't get all the data from these places, we try to estimate as much as possible to be able to get some level of accuracy with our data. But what we hope to do with this elimination strategic plan is to make sure that we bring the community pharmacies and over-the-counter medicine shops on board, create a reporting system where they can report to, because we know that a significant number of people attend or visit these places for healthcare. And so we hope to get them on board, get data, train them, supervise them to make sure they are testing appropriately, they are treating appropriately, they are referring appropriately, and make sure that we get also accurate and timely data from pharmacies and over-the-counter medicine shops for us to be able to get accurate national data on malaria.
All right. We have a caller from Dunkwa. Is it Tasha or Sasha?
From Dunkwa, Government Hospital.
What's the name?
I'm Shasha from Dunkwa Government Hospital.
Oh, Shasha.
Shasha. Okay.
Yeah.
All right. Shasha, please, what are your thoughts?
Good morning.
Good morning.
I'm sending my greetings to my honorable Dr. Watson.
Right.
The joy is talking about malaria.
Right.
So send my greetings to him. Say Shasha. He was working in the government hospital.
All right. All right. Thank you.
May I know why the mosquitoes like the hospitals too much? Like the government hospital. Most of our mosquitoes, they came here in the evening, so I don't know why the mosquitoes are worrying the hospitals. And so what can we do to prevent it? Normally the malaria control was coming to spray us for us, but this time they have stopped. So a lot of people are getting malaria. So what can we do? So we should do something so that malaria can be reduced from Bukaw and stop this thing. This time I was listening to our dear doctor, Dr. Watson.
All right. All right. Thank you, Shasha. Obviously, this is someone you know.
Yes, I know. I know Shasha very well. I used to work at the hospital. So
Okay, in Dunkwa.
Yes.
Oh, okay.
That's in the central region. And it's quite funny what he said. Some people say that you
go to hospital now. The mosquitoes will it's like a gathering. Meet me there.
Yes.
When you come to the hospital, the mosquitoes are like, here we are. I see.
But I think that is a valid concern, and I think that health facilities across the country have to take this seriously. And we try to provide insecticide-treated nets in health facilities for patients to sleep under when they are admitted. But the challenge was that, hygiene-wise, people sleeping under them, leaving, keeping the nets clean and all of that became a challenge. And so I think that just a few facilities are practicing that now. But I think that I'll encourage health facilities across the country to look at managing their environment very well. Most likely there are collections of water around the hospital or health facility environment where they are not managing very well. So beyond just providing bed nets or even waiting for a national program to come in and undertaking the residual spraying in the various wards, we can also look at how we can manage our environment, clear breeding collections of water that breed mosquitoes, clear those areas, and make sure that at least we can also do something in our own way to reduce the number of...
It's a collective effort.
Yes.
We have our role to play.
Yeah.
You guys have your role to play as well. We have Edmund from Dentura. Edmund, good morning.
Yeah, good morning. Actually, it is Tupuhiman Lewa Dentura.
Right.
I have to work. I'm working at the health directorate.
I see.
Yeah.
What is your take? Do you also have mosquitoes, in your hospitals playing games with your patients?
Not that. Really, it's not happening in our setup now.
I see. Okay.
Yeah, I'm actually online on Eradicating Malaria, and I want to contribute to your program.
Please go ahead.
All right. Actually, Eradicating Malaria has been a national policy of Ghana Health Service, and there have been series of programs and policies gearing towards that. For the past 4 years, there has been introduction of RCSS, which is malaria vaccine. So looking at the situation where on your bulletin you made mention that there has been a reduction in malaria prevalence from 27-point-something% to I think about lower, something about 8 or 9%. So bringing it to your notice that there has also been a policy where they've introduced RCSS, which is malaria vaccine, where children under 5, so from 6 months to 5 years, they are given RCSS vaccine. And it has also contributed immensely to reducing malaria under 5.
Yeah.
Okay.
And the mortality as well among children under 5. So we are making a huge impact in Ghana Health Service with this policy.
And we thank you for the good work for Mother Ghana. We're grateful to you.
Thank you, and thank you to all the staff.
Right.
To Queen Malawad in Tra District.
So we're getting interesting calls, Dunkwa, Dentura, and other places. Okay, I have some comments coming through. This one says, Mohammed Ibn Isaka, before you react, the simple way to eradicate malaria is for governments to employ sanitation workers and equip them efficiently to work. They must ensure regular salary payments for these sanitation workers. Our gutters should be enclosed ones or not open gutters, as is happening now. Our current open gutters should be sprayed regularly and desilted regularly. Gone are the days of the town council or tankase. If tankase came to you, it meant that Charlie. Asemato. This one comes through from a respected professor in the sciences. And he says, good morning, Ben. I want to believe the Ghana Health Service is talking about elimination of malaria, not eradication. They are quite different. I have now heard some of the GHS callers saying eradication. I think that is not correct. So please clarify elimination versus eradication, because I think eradication is more...
Yes, so eradication is more global. So global eradication of malaria. But elimination is...
Localized?
Yes, localized. So in a particular geographic area or specified area, yes. So the right term to use is elimination of malaria if you are referring to Ghana or some parts of Ghana. But eradication is a global agenda.
All right. Thank you for that clarity. And thank you, Prof. I know you usually don't want me to mention your name, which is why I'm not mentioning your name, but I saw your comments. Thank you for shooting them through. You can still call that number 0302-211-691, 0302-211-691 as we get ready to wind down on this conversation.
And I'm happy about the comments on the malaria vaccine. And I think it's something that the government hopes to, or the Ghana Health Service hopes to roll out across all districts by 2028. And it's part of
these will be
prevalent,
predominantly for children.
For children under 5 years.
Children under 5.
Yes. Okay. So usually it's incorporated into our routine immunization system, given when the children go for weighing. So at 6 months, 7 months, 9 months, and then at 18 months.
Oh, so it will be taken in doses and different batches.
Yes. And we found we reduce the incidence of malaria, reduce the incidence of severe malaria, and these children dying from severe malaria as well. And so we hope that currently there's a number of districts that are implementing the malaria vaccination, but by 2028, the plan is to make sure that all districts across the country come on board and have malaria vaccination as part of the interventions within their districts. Yes.
That's an interesting one. Do we have a call on the line?
Yeah.
Moses from Bolga. Good morning.
Good morning.
Thank you for calling. What are your thoughts for us?
Yeah, my thoughts are that the professional there, the doctor there.
He is Dr. Boateng.
Yeah, the doctor in George.
Yes.
He's only putting that into our eyes.
Hey.
I want to ask him whether the professional, whoever came to Bolga here, organized a program educating us about malaria and how to educate it. So, as if we are not Ghanaians, are we Ghanaians at all?
But just to find out from you, the mere fact that you may not have seen doesn't mean they've not been there. You know that, right?
I'm in Bolga Central here. You're saying that I haven't seen. If something is going on in Bolga here, as a pastor, so I wouldn't see. I myself have gone to. I was listening about 2 weeks ago. Everything I have to buy. And even buying still are not still well. So what is it?
Wait, are you talking about payments when you go to hospital to treat malaria, or you are talking of...
Including even the doctors these days, the way and manner, sometimes they train the what? The wrong people.
Okay.
They don't know anything. You see, you go to hospital and they'll tell you that, we can detect type little bit in your system. Now, they are the drugs, all the drugs for you to go and buy. And you go and buy, then for about a week, you go for review. And now they are telling you that it is BP to the highest level, admitting you. So the first time, why is it that BP to the highest level? They could not detect it at first. Now they say typhoid, from typhoid you go for review, and it is now BP.
All right. Thank you, Moses, for sharing your thoughts with us. So interesting comments from Moses, because he seems to suggest that he is basically saying the doctors we are putting out may not necessarily make the cuts. That is one. And I know that sometimes people have some of these questions. He also, I think he was talking about the cost when you go, even with your national health insurance and all of that. And then I think the third point was that, look, if you guys embark on these drives and all of that, speaking to people about malaria education, how come he's never met you? How do you address these issues?
So one, I think that education is a continuous effort. And I think even this platform offers us a good opportunity to put the message out there. So at least I'm happy that he's listening to this program and he's heard about malaria elimination in Ghana, the hope of us eliminating malaria in Ghana. And I hope that some of the interventions that we put across and some of the preventive measures that he can take to prevent malaria, he'll be able to adopt them. So I'm happy at least he's listening to this program. And actually, we do a lot of education, also what we call social behavioral change activities across all parts of the country. And if he hasn't heard about any of our various interventions in terms of social behavioral change communication, I'll say that's unfortunate. But it also tells us that we still have to do more beyond what we are doing now. So we have to make sure that we engage all appropriate media, from social media to traditional media to even community information centers and every means possible to make sure that we reach all the population. They have adequate knowledge, adequate attitude about malaria prevention and malaria treatment. So it's something that is some little feedback that we can take and try to improve upon our social behavioral change communication intervention as well.
Right.
The other part is that malaria treatment, diagnosis and treatment is covered under the National Health Insurance Scheme. And so ideally it's supposed to be free. If there are any challenges in terms of people paying for that, I think that we have to look further into it to see why that is happening. But ideally, it's supposed to be covered by the National Health Insurance Scheme.
So maybe you might want to cast your lenses towards Bolga and see what is happening.
Yes. And there are so many
Bolga
malaria interventions we undertake in the upper issue, and specifically Bolga. And one key one is what we call seasonal malaria chemical prevention, which I mentioned earlier. And there's a huge education that goes along with that. But as indicated, we'll still work hard to make sure that we reach everyone across the country.
All right. Any final words, Doc, before we wrap?
I would say that malaria elimination is possible, as has been demonstrated by other countries that have been able to do that. And I would say that malaria elimination is not just a health sector effort, but all of us have to come on board. All sectors, from education to agri to environment to sanitation, all of us have to be on board to make sure that this elimination agenda is achieved.
Okay.
The other thing too is that communities have to take leadership and ownership of this elimination activity. They don't have to wait for national or the region to come with money before they can take action to prevent breeding of mosquitoes and prevent themselves from being bitten by mosquitoes and getting malaria. Communities should sit down, districts should sit down, various communities sit down, look at where mosquitoes are breeding, take action to clear these areas, okay, and not wait for national to come to them. I also want to implore on the private sector to support this elimination agenda. They should make sure that they support us either financially, logistically, by all means possible for us to be able to achieve this elimination agenda. And as we always say, zero malaria starts with me and it starts with you. So let's all take action towards zero malaria in Ghana.
Well, thank you very much and keep up with the good work. Dr. Paul Boateng joined us this morning. He's the focal person, malaria case management at the Ghana Health Service. Stay with us on the AM show. There are still some very germane conversations we have coming your way after the break.